All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance and policy keeps giving microbes the home field advantage. So let's start today's podcast with the news, because if you feel like you've been hearing the phrase highest in decades a lot lately, you're not imagining it. Today's updates: measles is back in a big way in the United States, dengue is surging in Sri Lanka, Ebola is burning through parts of Congo, screwworm has crossed into Texas, polio is still not done with us, and we now have new evidence that a single shot can protect newborns for more than one serious infection. So let's start with our news. Measles first. The United States has already recorded 2,295 measles cases just in 2026. That's more than last year's total and the highest annual count since 1991. This is for a virus that we've declared eliminated in 2000, that we absolutely know how to prevent. About 10% of case patients are under the age of 5, and 10% of adults 20 and older have needed hospitalizations. Think of a little league team of 10 unvaccinated kids. In a measles outbreak, almost all of them will get infected, and roughly one of them ends up sick enough to land in the hospital. This is not a minor childhood rite of passage. This is policy failure. So health experts are clear about the surge that is driving this is obviously as a result of declining vaccination rates, which have pushed some communities below the roughly 95% coverage needed for herd immunity. We've loosened school entry rules, we've allowed broad non-medical exemptions, and we've underfunded the mundane, grinded out work of research outreach. When the smoke detectors are turned off by policy, measles doesn't politely respect the elimination label, and kids who pay the highest price are often those who didn't get a real choice to begin with. For instance, there may be infants too young for full vaccination, immunocompromised children, or families with fewer resources to navigate an outbreak. Okay, let's move to Sri Lanka, where dengue is having its own record-setting year. As of July 23rd, Sri Lanka has logged more than 80,114 dengue cases and 59 deaths, with more than 24,000 cases just in July alone. It's the worst month so far and the worst outbreak in nearly a decade. Officials point to a new mosquito breeding grounds created after a large cyclone last December. The government has literally asked the military to use drones to scan rooftops and for stagnant water where mosquitoes breed. When your vector control strategy needs drones and soldiers, that's a visual way of saying we didn't invest enough in prevention. Poor drainage, patchy waste management, and slow infrastructure repair turn entire neighborhoods into mosquito nurseries, and again, not randomly, but in the places with the least political clout. Let's go to Ebola. In the Democratic Republic of the Congo, Bundibugyo strain Ebola outbreak has been described by WHO officials as the fastest growing Ebola outbreak on record. Recent data from Congo's Public Health Institute show more than 2,500 confirmed cases and over 1,000 deaths, with dozens of new cases detected in a single day in some eastern provinces. Violence, attacks on clinics, shortages of staff and supplies have made it extremely difficult to contain the outbreak, and viruses have spread into new provinces beyond the original epicenter. This is what it looks like when a fragile health system and chronic conflict meet an unforgiving virus. It becomes a fire, and to quote the WHO, that burns people least able to evacuate. Even in the U.S., Ebola is shaping policy decisions. 14 American citizens returning from the Congo were quarantined at a New York military base for 4 days, despite being asymptomatic and not considered a transmission risk. Quarantine is a policy tool that can be used, that should be used carefully, or it can be used performatively. When we aim to show more of that we're doing something, then we're actually following evidence-based risk assessment. People with less power, aid workers, migrants, local residents are often the ones who get stuck in the most restrictive least transparent measures. And let's talk about a different kind of parasite now. We'll be talking about the other one in just a moment. But let's talk about the New World screwworm. And we're going to be talking about screwworm a lot coming up, because I think this is so important and so indicative. That is the theme of a lot of what Resistance Radio is about, how policy failure is 100% the cause of what we see when we see public health failures. So what is the screwworm? It is a flesh-eating fly whose larvae burrow into open wounds of warm-blooded animals. And yes, it's as unpleasant as it sounds. The USDA first reported a case in a Texas calf in early June, and additional reports have brought the U.S. animal case count into the teens and then higher as more cattle and other livestock have been identified with screwworm in Texas and nearby areas. For ranchers, this is not a scary headline. It's a direct threat to their herds and livelihoods. Now, the policy angle here is border and vector control. For decades, the U.S. invested in screwworm eradication through sterile fly programs and cross-border cooperation. These systems have to be maintained, funded, and modernized. Otherwise, climate shifts, trade, and animal movement make it easier for the parasite to slip back in. And again, the small operators in rural communities with fewer resources often have the hardest time protecting their animals and responding quickly. Let's move on to polio. And there's a report from the Center for Infectious Disease Research and Policy, a report that shows the new polio virus detections in Afghanistan, Nigeria, and Central African Republic. Each polio report is a reminder that the virus takes advantage of any pocket of low vaccination coverage it can find. These pockets are almost always reflecting conflict, displacement, or neglect. In places where basic childhood services are last to arrive and first to be disrupted. And I want to add one more piece to this news roundup, because it points to a quieter policy success, and that is a single immunization that seems to protect newborns from 2 serious diseases. So there was a French study of nearly 500,000 babies found that those who received Nirsevimab, which is an antibody-based shot given to prevent RSV, had a 36% lower risk of invasive pneumococcal disease. So this is a monoclonal antibody that's given to prevent a viral disease. Also showed that it decreased invasive pneumococcal disease compared with those who didn't get it, and that protective effect lasted at least 9 months. In human terms, imagine lining up 100 babies that are at risk for severe RSV pneumococcal infections with this Nirsevimab on board. Roughly a third fewer end up facing serious bacterial disease. It's a huge win for families in pediatric wards. But again, the benefit depends on policy decisions. How will this shot be covered? Will it be covered for all newborns or only those with certain insurance? Will rural clinics and safety net hospitals be supplied and reimbursed adequately? And if this becomes a luxury item instead of a standard of care, we'll have turned a scientific victory into yet another inequity. All right, so let's zoom into the story that everybody's been talking about, and of course, this is Cyclospora and the shredded iceberg lettuce that it has been associated with. Because if you've gotten sick from a salad, you know that betrayal cuts deep. So cyclosporiasis is caused by a parasite called cyclosporas. We know is a microscopic parasite that infects the small intestine system. Symptoms include severe watery diarrhea, nausea, loss of appetite, weight loss, and fatigue. And they can last for weeks if untreated. This summer, Michigan, Ohio has seen unusually high numbers of infections. The Michigan Department of Health and Human Services is reporting over 6,000 cases with over 100 hospitalizations, while in Northwest Ohio, Lucas County alone has logged in almost 1,000 cases with more than 2,000 across the region. Investigators in Michigan did what good epidemiologists do. They sat down with people, asked, what did you eat? They looked at 190 food exposures from Taco Bell and found that 90% of people with cyclosporiasis said they'd eaten iceberg lettuce at one of their restaurants. That's not random. That's a flashing neon arrow pointing at a common ingredient. Michigan sent those findings to CDC, who then examined the data from over 1,500 people who had cyclosporiasis from May to July, and also visited a Taco Bell restaurant trying to understand the origin of the outbreak. Now, the pattern led FDA's traceback investigation straight to Taylor's Farms de Mexico, the supplier of shredded iceberg lettuce used by Taco Bell across multiple states. And at one point, a lab test seemed to find Cyclospora in a sample of lettuce, but later quality checks revealed that result was a false positive. Even so, the FDA has emphasized that the recall and the link to Taylor Farms of Mexico are based on the epidemiology and supply chain data, not just one lab test. Now, why is it hard to get a clean, definitive answer from testing? That's because Cyclospora can't be easily grown in the lab. So we're stuck with a direct detection from stool or from food samples. And if only a few parasites are clinging to a big batch of lettuce, your odds of catching one in a small piece you swab and test aren't great. This was summed up nicely by a colleague of mine who said when contamination sits near test detection limit, you may or may not get a positive signal. And because it takes only 1 or 2 weeks for symptoms to show up, by the time people are sick and seek care, most of the implicated lettuce has already been chopped, shipped, consumed, and or thrown away. Now, this is where policy and power slip into the salad bowl. Routine stool testing panels in the US, labs, do not always include cyclosporin, and a clinician has to specifically request cyclosporin PCR or specialized microscopy. That means that doctors are oftentimes rushed. I know that I am all the time. Clinics are under-resourced or whose symptoms don't fit neatly into the mental template of a parasite may never actually get that right test ordered. And some people are told to collect multiple stool samples on different days, which is not exactly easy when you're working hourly shifts, caring for kids, or living in housing that doesn't make specimen collection simple. Now, on the food side, our regulatory framework for produce has slowly improved, but it doesn't fully account for parasites like Cyclospora in complex international supply chains. Lettuce grown outdoors is exposed to whatever's in the water and soil, and washing doesn't always remove microscopic oocysts. Yet, we still treat salad as healthy by default and assume it's safe until an outbreak forces a recall. The people who are most likely to rely on fast food salads are folks looking for the cheapest, quick, leafy options, and are often the same people who have the least bandwidth to navigate weeks of diarrhea, multiple clinic visits, and complex testing. All right, so let's move into a deep dive that I promise I'll keep light and understandable, and that is the resistance gene, also called NDM, which stands for New Delhi New Delhi metallobeta-lactamase. We're going to call that NDM. This is now called a nightmare resistance genes. It's referred to as a nightmare for hospitals. If you think of antibiotics like tools in a toolbox, NDM is like the rust and glue combo that suddenly makes your best wrenches and screwdrivers stop working when you need them the most. This is a gene that tells bacteria how to make an enzyme capable of breaking down some of our strongest antibiotics, including a class called carbapenems, which is a relationship of a cousin of penicillin. Now, carbapenems are drugs that clinicians reach for when everything else has failed. These are the break the glass in case of emergency antibiotics. I use them all the time for my patients in the hospital. When a bacterium picks up the NDM gene, many of those emergency options are now effectively wiped out. They vanish. So we see NDM most often in a group of bacteria called, of course, carbapenem-resistant Enterobacter, or CRE. It's a mouthful that includes organisms like Klebsiella, which can cause pneumonia, UTIs, or bloodstream infections, wound infections, especially in hospitalized patients, nursing home residents, and people with serious underlying health issues. Put simply, these are the infections that show up in places where people who are already sick and vulnerable. So now, the surveillance data by the CDC that has been recently summarized show that infections with that bacteria, CRE, carrying that resistant gene, NDM, have increased 450% between 2019 and 2023 in the US. To translate that, If a hospital saw about 5 NDM positive infections in 2019, by 2023, they're seeing more than 20. That's like going from a rare, scary visitor to a regularly unwelcome guest on your ward. And that's the really sneaky part of how NDM spreads. The gene often lives on things that are called plasmids. These are small mobile bits of DNA that bacteria can share, kind of like gossip. Instead of waiting for slow generational changes, one bacterium can essentially hand another bacterium a little piece of genetic instruction, and it says, here's how to destroy carbapenems. It's kind of like thinking about it as bacterial peer-to-peer learning. And clinically, this means that we're increasingly facing infections where the routine antibiotics don't work, the heavy hitters don't work, and we're left with only a few drugs that may be toxic, that are hard to dose, or are widely expensive. Infectious disease and pharmacy teams scramble to put together salvage regimens, but there are cases when even in well-resourced hospitals that we don't have reliably effective options. And for patients in safety net hospitals or long-term care facilities where access to the newest agents may be limited, that situation can be tougher. So where's the policy in all this? Pretty much everywhere. For decades, antibiotics have been overused, misused in both the human medicine and agriculture, prescribing broad-spectrum antibiotics for minor viral illnesses, long courses when short ones would do, and using antibiotics as growth promoters in livestock. Each unnecessary dose is a tiny vote in favor of resistance. We shouldn't be surprised when genes like NDM get selected and spread. We actually set that table. So at the national level, resistance surveillance and new antibiotic development require long-term instruments that don't always make for flashy press conferences, and surveillance systems that spot NDM trends need modern lab capacity as well as IT. New drugs that can tackle NDM-producing bacteria often face tricky economic realities because of using them sparingly to preserve their effectiveness doesn't fit well with traditional pharma business models. And if we don't want NDM to keep winning, our policies around funding, reimbursement, and incentives have to change. So for the general listener, here's a bottom line. NDM is a genetic trick that some hospital bacteria have learned, one that disables some of our best antibiotics. Its rise is not just a science story. It's a story about how we've treated antibiotics like limitless resources, how we've underfunded the people and systems that protect patients, and how those choices land hardest on people with the least power, patients in crowded facilities, communities without strong hospital systems, and those who can't easily advocate for cutting-edge care. So if tonight feels like a whirlwind, measles back at a 35-year high, dengue surging with help from climate and infrastructure, Ebola racing through conflict zones, screwworm chewing through cattle, polio persisting where vaccination rates falter, lettuce-linked cyclosporiasis, and an invisible resistant gene quietly sabotaging antibiotics, well, that's the point. None of these events are isolated. They're threaded together by policy decisions about who gets protection, who gets resources, and whose risk is considered acceptable, okay? Because public health failure is almost always public policy failure. When we let vaccination coverage slide, measles fills the gaps. When we neglect drainage and waste management, mosquitoes thrive and dengue surges. When we underfund outbreak response in conflict zones, Ebola is going to find the room to grow. When we relax surveillance and agriculture controls, screwworm and polio exploit the openings. And when we accept fragile food safety oversight, cyclospora shows up in the cheapest salad options. And when we treat antibiotics like bottomless commodities, NDM and its cousin rewrite the rules inside our hospitals. So the people that are most affected are rarely those sitting at policy tables. They're kids that are in unvaccinated or undervaccinated communities, families living near standing water and poor sanitation, patients in safety net hospitals, workers grabbing fast food salads on the way to a shift, and caregivers trying to navigate complex healthcare system with limited time and money. If we want a different microbial future, we just don't need to do better science. We need different choices from the people who are in power. This is Resistance Radio, where natural selection selects resistance, and our job is to resist the idea that any of this was inevitable. Thank you for tuning in.